So welcome to my channel, guys, and in this video we are going to talk about indirectly acting cholinergic agonist. Okay, so we are going to talk about the indirectly acting cholinergic agonists. Indirectly acting cholinergic agonists are divided into two types. There are reversible and irreversible. So what indirectly acting cholinergic agonist does is they bind with the acetylcholine esterase enzyme. So this acetylcholine esterase enzyme break down the acetylcholine. Okay, so when indirectly acting cholinergic agonists bind with this acetylcholine esterase enzyme, they break down this acetylcholine esterase and they increase the acetylcholine in the synapse. Okay, and thus uh, there is more biological action, or it can be said that the acetylcholine acts more on the receptors, so they give more biological action. Okay, so more receptor activation and more biological action. Okay, so it can be divided into reversible and irreversible reacting cholinergic agonists. So why it is called reversible? Because these drugs binds with acetylcholine esterase with weak bond that can be break down easily. That can be a hydrogen bond. Okay, hydrogen bond, or can be van der Waals bond. Okay, these are the weak bonds and they can be break down easily. And there is the irreversible. They bind with the acetylcholine esterase with covalent bond, and it is a really strong bond and it can't be break down easily. Okay, so they are divided into reversible and irreversible. So reversible indirectly acting cholinergic agonists can be again divided into alcohols and carbamates. Okay, we have adrophonium in the alcohol group. In the carbamates, we can again divide them into tertiary amines and quaternary amine. Okay, so tertiary amines are more lipid soluble, and they can cross biological membranes easily. Well, because they are lipid soluble, so they can enter into they can penetrate the blood-brain barrier and can enter into the central nervous system. But quaternary amines are water soluble and they can't penetrate the blood-brain barrier. In tertiary amines, we have rivastigmine, donepezil, galantamine, and physostigmine. Okay, and in quaternary amines, we have neostigmine and pyridostigmine. Okay, in irreversibly acting cholinergic agonist, irreversible, we have the compounds called OPC compounds, or organophosphate compound, organophosphate compounds. Okay, So in organophosphate compounds are ecothiopate, we have serine. So they bind with the acetylcholinesterase irreversibly, and there is something called alkyl group in these organophosphate compounds. Okay, so they have the alkyl groups in the organophosphate compound. If this group detach, from the organophosphate compound, like if it is acetylcholinesterase and this is the organophosphate compound, and there is the alkyl group. Okay, there is the alkyl group, and this alkyl group detached from the organophosphate compound. When the organophosphate compound is binded with the acetylcholinesterase and this alkyl group detached from the OPC compound, this bond or this organophosphate and acetylcholinesterase bond can't be break down. Okay, so if this alkyl group detach after binding with acetylcholinesterase, OPC compound can't be detached from the enzyme, and this thing is called aging. Okay, this thing is called aging. So why this aging is important? Because in the OPC poisoning, it's a common poisoning case of organophosphate compound poisoning. In organophosphate compound poisoning, we have the antidote called pralidoxime, and this pralidoxime break down the bond of organophosphate compound, like this organophosphate compound binded with the acetylcholinesterase. Okay, so this pralidoxime break down this bond with acetylcholinesterase and between the acetylcholinesterase and the OPC. Pralidoxime break down the bond between the acetylcholinesterase and OPC. But if the OPC compound goes to aging, which is done after 8 to 12 hours of poisoning, pralidoxime can't break down this bond, right? So pralidoxime can't break down this bond. If a patient comes to you who has been poisoned by the OPC organophosphate compound, so he comes to you after 8 to 12 hours of poisoning, so you shouldn't give him pralidoxime. So pralidoxime should not be given after 8 to 12 hours, because after that time, pralidoxime there's no use of pralidoxime. So pralidoxime can't break down the bond and can't make the reaction reversed. So there is no use of pralidoxime after 8 to 12 hours of OPC poisoning. Okay, so this is why this aging is important. We have ecothiopate in our OPC compound, and it has some pharmacological importance because it is very long. It has very long duration of action. Okay, so because it has very long duration of action, so It has pharmacological importance. It is used in glaucoma, though it is not commonly used due to its side effects like cataract formation, diarrhea, muscle weakness. But we can use it in resistant type of glaucoma. Okay, so where no drugs is useful, or when other drugs fail to work in the glaucoma, then we can use these drugs. So ecothyphat can be used in resistant glaucoma. And we have the serine, and serine is a potent nerve gas. Okay, so it's a potent nerve gas. Okay, so let's talk about the reversible indirectly acting cholinergic agonist. So in reversible, we have already talked about the names of the reversibly acting drugs. Then we want to talk about the myasthenia gravis. So myasthenia gravis is a disease where the autoantibodies against, there is production of autoantibody against nicotinic receptors. Okay, so we have the nicotinic receptors in the neuromuscular junction, and if autoantibody is produced against this nicotinic receptor, then these receptors get internalization. So goes into internalization. So receptors goes into internalization and destruction. Okay, and this causes muscle weakness, and even muscle paralysis or paralysis. Okay, so let's see that. Let's change the color. So if this is a neuromuscular junction and these are the nicotinic receptors, so autoantibodies are produced against these nicotinic receptors and they destroy or internalize. So the nicotinic receptors goes into the cell and gets destroyed. Okay, gets destroyed, and that's why. So acetylcholine, if you have acetylcholine can't act on this receptor, and it causes muscle weakness and muscle paralysis. Okay, in this condition, we use a drug called neostigmine. Okay, so why we use the neostigmine drug in the myasthenia gravis? Because if you can remember that I have already said that neostigmine is a quaternary amine and it is a water soluble drug, so it has no central nervous system effect, no effect on the central nervous system, and it is more likely work on a neuromuscular junction, where the nicotinic receptors are located, and it can also act directly to nicotinic receptor. Okay, so what is the mechanism of neostigmine in the myasthenia gravis? That they in myasthenia gravis due to autoantibodies. Okay, due to autoantibodies, nicotine receptors are less. Okay, so there is less amount of nicotine receptors. So what neostigmine does is it binds with the acetylcholinesterase, and acetylcholinesterase is blocked. So it's blocked by the neostigmine. And so there is increased acetylcholine in the neuromuscular junction. And increased amount of acetylcholine acts on the reduced number of receptors, and this causes reversal of the paralysis or reversal of muscle weakness. Okay, and it improves the myasthenia gravis. In myasthenia gravis, we also use the drug called steroid because it's an autoimmune disorder and there is increased inflammation. So we use a steroid as an anti-inflammatory drug. And there is thymus removal. Okay, so surgical removal of the thymus can be done because the autoantibodies are produced into the thymus gland, so that thymus removal can be done in myasthenia gravis. There is another disease called Eaton-Lambert syndrome. So what happens in Eaton-Lambert syndrome is there is autoantibodies produced against the calcium channels or presynaptic calcium channels. So autoantibodies destroy the presynaptic calcium channels. Okay, so by destroying the presynaptic calcium channels, they causes muscle weakness. Let's see how it is done. So if this is a neuromuscular junction, let's see that this is the neuromuscular junction, and this is the acetylcholine is in the vesicle, and this is the calcium channel, presynaptic calcium channel. So autoantibodies are produced against these calcium channels and they destroy this calcium channel. Okay, so when calcium channels are destroyed, calcium can't move in through the presynaptic calcium channel into the presynaptic nerve terminal, and it can't release the acetylcholine from presynaptic nerve terminal to the synapse. So no acetylcholine is released. Okay, so no acetylcholine is released into the presynaptic nerve terminal, so that it causes muscle weakness or muscle paralysis. We also use neostigmine in this case, and it causes obviously block the acetylcholinesterase and increases the acetylcholine into the synapse, so that reverse the muscle paralysis or muscle weakness. And we also use neostigmine in the reversal of anesthesia. In anesthesia, we use the muscle relaxants. Okay, muscle relaxant, and this muscle relaxant block the nicotinic receptor. Okay, so block nicotinic receptor, block nicotinic receptors. What neostigmine does is neostigmine increases the acetylcholine in the synapse, and also it acts directly on the receptor. So it replaces the muscle relaxant drug by acetylcholine and neostigmine itself. So if this is the neuromuscular junction and this is the nicotinic receptor, so before there is a muscle relaxant on this nicotinic receptor, and now neostigmine and acetylcholine they replace this or make this muscle relaxant go away from this nicotinic receptor and bind with this nicotinic receptor and activate the nicotinic receptor, and that's how they reverse the action of the muscle relaxants in anesthesia. Okay. There is another drug called adrofonium. We have already talked about the myasthenia gravis, and we use neostigmine in the as a medication in the myasthenia gravis. But adrofonium is used in the diagnosis of myasthenia gravis. It can't be used as a drug for for the improvement of the disease because it has very short duration of action, so that it is used as diagnosis in the diagnostic cases like diagnosis of myasthenia gravis. It is also called Tensilon test. Okay, so if a patient comes with muscle weakness, then give him 2 milligram adrofonium. Okay, and wait for 45 seconds. If there is any reaction, you don't have to do anything. After 45 seconds, so give him 2 milligram adrofonium and wait for 45 seconds. If any reaction is shown by him, then again give 8 milligram adrofonium. If there is an improve in muscle weakness, that means he is suffering from myasthenia gravis. Okay, and if it doesn't improve there is no improvement in muscle weakness, then it is not a case of myasthenia gravis. Okay, then it is also used to differentiate. So adrofonium is also used to differentiate between myasthenic crisis and cholinergic crisis. Okay, so what is myasthenic crisis and what is cholinergic crisis? Myasthenic crisis is the In myasthenia gravis, there is sometimes increase in autoantibody production. So what happens is myasthenia crisis or myasthenic crisis, uh, there is increase in autoantibody production, and there is increase in muscle weakness, and there's another thing called cholinergic crisis. Okay, cholinergic crisis. So there is decrease in autoantibody production, and so the autoantibodies are reduced, so there is toxicity of acetylcholine due to the neostigmine drug. Okay, due to the cholinergic drugs. So cholinergic crisis is the toxicity of acetylcholine, and this also causes muscle paralysis. So how will you determine that is it myasthenia crisis or it is cholinergic crisis? So a patient is you are giving a treatment to a myasthenia gravis patient, and he comes with again to you after some few months, 2-3 months, that he again faces the problem of muscle paralysis or muscle weakness. But he is on he is continuing his drugs. So how will you determine that is it a myasthenic crisis or is a cholinergic crisis? So again, give adrophonium to the patient, and if improvement occurs, then it is myasthenic crisis. Okay, myasthenic crisis. So in this case, you have to increase the doses of neostigmine. If not improved, then it is cholinergic crisis. If not improved or it gets worsened, then it is cholinergic crisis, and you have to reduce the doses of neostigmine. Okay. Then there is another condition called Alzheimer's disease. And there is decrease in cholinergic stimulation to CNS. Okay, so in this Alzheimer's disease, we use donepezil, rivastigmine, and galantamine. We use these drugs because they are the tertiary amines, and they can easily cross the blood-brain barrier and increase the acetylcholine into the central nervous system, and that improves the Alzheimer's disease. Okay. And there is another drug we have that this is physostigmine. Okay. So physostigmine is used in atropine toxicity. We also use in tricyclic antidepressant toxicity, and also in phenothiazine toxicity. Okay. So what are the side effects of using these drugs? So they can cause convulsion, and they also can cause paralysis, diarrhea, meiosis, urinary retention, sorry, urinary retention, not urinary retention. It can cause urinary incontinence, salivation, lacrimation, flushing. Okay. So that's all for this video. Thank you very much.